Welcome, everyone. This is kind of a special day. It's the beginning of a professional series that we're doing from Gordon Medical Associates. And we're going to start it off with a special guest, Dr. Steve Harris, who has, Steve has folded his practice into ours. And it's been a real joy to have someone of Dr. Harris's well, not just his character, but his experience to share ideas with patients and to learn. And we've been having, it's only been 6 months, but we've been having a really good time. And today we're going to talk about plasmapheresis. Now, this is new to us, and I think fairly new to the world of chronic complex illnesses. And we're figuring out how to make use of it. And we're going to start off today. We're going to go through first a little bit about what plasmapheresis is, and Dr. Harris will give a little overview of that and different forms. And then we'll talk about the machines that are available in America and some of the clinical aspects of it. And then at the end, we'll talk more, hopefully a lot about how we use it and where we see it going. And I think we'll also talk a little bit about the anti-aging aspects. So that's our agenda. And we'll get going now with Steve. You want to talk a little bit about the plasmapheresis, its indications and what we can do with it?
Sure. Thanks, Eric. Hi, everyone. I appreciate being here. So plasmapheresis it actually isn't that new. It was first, I think, used in the early 1910s, like 1915, I think was its first application in a manual way. And then in the 1950s, it picked up and is now becoming more and more common as we speak. There was, I think, about 7,500 scientific papers that have been written in the last 15 or 20 years on plasmapheresis and its various modalities. So we're going to be primarily talking about therapeutic plasma exchange, but just plasmapheresis in general is basically separating cellular components from circulating factors, taking someone's blood and removing a toxic substance. And so by doing that, we are using an extracorporeal machine that separates out red cells, white cells, platelets that stay with the body in a holding tank, while plasma is either removed and discarded or is cleaned and then put back into the body. Primarily what we're going to be talking about is where the plasma itself is removed in a term called plasma exchange. There's two different kinds of therapeutic plasma exchange. One uses centrifuges to remove the plasma, and another kind is using a plasma membrane where the plasma gets filtered and then usually in this case often discarded. There are more selective kinds of plasmapheresis. What I'm talking about with therapeutic plasma exchange is quite non-selective, where you're basically removing everything that is less than 0.3 microns or so, which is the plasma, the albumin, antibodies, circulating factors, cytokines, lipoproteins, etc. And then keeping the red cells, and then replacing the fluid, the plasma fluid, with either with an equal volume of either colloids like albumin, usually a 4% albumin solution at equal volume, and or mixed with saline, albumin mixed with saline sometimes, or using fresh frozen plasma. So this process is the indication again is really the general thought is to get toxic substances from the plasma out of the body. The American Society for Apheresis, or ASFA, has developed based on evidence, and the evidence is still somewhat scarce. The numbers really aren't that high in the studies that they're using, but they're grading the evidence, and they've come up with 4 categories for indications. Category 1 is where apheresis or plasmapheresis or plasma exchange, whether there's could be the non-selective kind, a semi-selective kind, which is where you're filtering out the plasma and plasma components based on size and putting back in that clean plasma, or selective, which is where you're actually using and things like lipoprotein apheresis and a few other kinds not usually done in this country, which I think we'll talk about in a little bit. Some problems with that, but then also after removing the lipoprotein A, some cholesterol through a secondary column, putting that cleaned plasma back in. So the for plasma exchange, the category 1, which is where it's first line, that is generally things like acute or chronic demyelinating polyneuropathy, CIDP, Guillain-Barré, various glomerulonephritis, Goodpasture syndrome, and things like that, and liver transplantation desensitization, myasthenia gravis, renal transplant desensitization when there's antibodies, some kinds of angiopathies like a thrombotic microangiopathy and such, and then a fulminant Wilson's disease. So there's not a lot of category 1 indications. There's quite a few more category 2 indications, such as acute disseminated encephalomyelitis, and now recently PANS or PANDAS has actually become category 2, which applies to our practice quite a bit. However, multiple sclerosis even, and some overdoses and envenomations and poisonings often is considered a category 2. What category 2 really refers to is that yes, you can do it. It's really second line. You need to be doing your more standard procedures as well. A lot of this may be insurance related, but it's also good practice to at least do standard of care, and then you can quickly move on to plasmapheresis as needed. Category 3 is that where there's minimal evidence and needs to be individualized on a case-by-case basis. This is probably going to apply to many of the things that we do when we're looking at infections and other forms of toxicity, especially when we're not sure what the offending toxins or toxicants may be. But category 3, typically things like an aplastic anemia, neonatal lupus, burn shock resuscitation, different forms of pancreatitis, like a hypertriglyceride pancreatitis and things like that, and IgA nephropathy. There's a whole list, and Henoch-Schönlein purpura. There's thankfully the ASFA is always adding to the list, and so it's currently somewhat exhaustive, but I think as more data comes up, the more things will either change categories or be added as categories. Category 4 is, and one more thing that may be important for category 3, and there is quite a bit of research in this area, is sepsis. And several forms of sepsis is considered category 3, and there's some fairly decent data in hospitalized patients for sepsis. Thyroid storm, some forms of vasculitis, although not lupus, is also category 3, stiff person syndrome, etc. And category 4 is where it could be contraindicated, it could be dangerous, that it can be done under certain situations. Usually, at least in the literature, they discuss just getting an ethics committee approval from your institution. And that would include things like HELLP syndrome and dermatomyositis, polymyositis, amyloidosis, where the data may not show, but there's been anecdotes where it really can be helpful. There are some very real contraindications to therapeutic plasmapheresis. And the one is the most practical, where if you can't get good venous access, and then in the case of the plasma membrane therapeutic plasma exchange, where you actually need a central line because the speed and the volume of fluid that is moving, you need a port or a Grosjean 6 French, 8 French on that. Whereas with the centrifuge form, it goes a little bit slower. If you can get a large bore needle, 17 or 18, you can often do this with peripheral lines. Although many times we do like to have a double lumen catheter central line, either in the groin or neck, and some of the ports that we can also use. The other contraindications, of course, are hemodynamic instability, or of course allergies to fresh frozen plasma or to external albumin, allergies to heparin, a severe hypocalcemia, since that's one of the perils of doing plasmapheresis. And then the other one that's interesting is having used ACE inhibitors in the last 24 hours, because there's an increase in bradykinin, which with all kinds of plasmapheresis that can actually be life-threatening. So that's an absolute contraindication, actually. The main side effects of this process are mineral imbalances, primarily hypocalcemia. It becomes a bigger issue when you're using the centrifuge form, where you're adding heparin and not adding the citrate. Citrate will not cause as much hypocalcemia. Also, of course, low magnesium. You can get hypothermia. You can have hypotension, of course. You can have clotting issues, both bleeding or clots. There was a study that showed the adverse events, and that was done from I think it was of 50,000 therapeutic apheresis and plasmapheresis sessions that were performed, or patients. There was 7,000 adverse events. Most of them were mild, which was just things like that, where things didn't need the medication and engagement, and some of them were moderate. There was no deaths in this study of the 50,000 patients, but there was some severe hypotension and allergies that did happen, requiring intubation in some situations. So it's about so 7,000 out of 50,000 patients had some sort of adverse event. Most of them are quite mild. Many of them are related actually to just vascular access issues. And then things like the machine, the clotting, because not using either enough anticoagulant during the process, and things of that nature. A few other side effects are, of course, allergy or infection that you could get with colloid replacement. Not very common these days, but it can happen. And then I think the most common thing that we see is the need to readjust medications, especially if patients are on immunosuppressants or antibiotics or antidepressants, that we are going to, at least for those that are for plasma levels, we are going to be changing those levels quite a bit by removing the plasma. So many times these drugs are going to be taken out of the system quickly. And so we just need to take that into account when we're doing sessions. A few just practical matters that I think Eric will get into is just the different techniques for how to do this. There's some data about doing 6 sessions, and that with maximum benefit, you find 24 to 40 doing sessions every 24 to 48 hours. If you do them in consecutive days, A lot of times, if you're removing antibodies, which is what we're after, oftentimes the you give it with that extra time, you get a little bit of a chance for antibodies to come back into the plasma. And so there's been some pretty good data on that as far as how much antibody is removed, especially like IgM. You get like 60% of it out on session one, and then if you wait 48 hours, then you can get a total of like 75%, of antibodies out after two sessions. So the data is interesting on that as far as deciding the proper routine and schedule for doing this. I think Eric, do you want to talk about some details of
Yeah,
the
yeah.
machine and maybe fill in some gaps there?
I'm just gonna, let's see. I think the most important thing is, yeah, not the most important. There's so many interesting little details to this process, but one is, I like to wait 2 or 3 days because you do remove the clotting factors, and again, in most of our patients, we're we don't have to go so fast. I mean, like, Monday, Wednesday, Friday is good. Monday and Thursday, alternate weeks is also good, because you will get replenishment of the IgG and the IgM, but basically on like day one for IgG, you're taking out all the IgG that's in the plasma, but about 50% of your IgG is hanging out in tissues. So the next time you go, you're going to get about 25%. You're going to get half of that. So it'll keep going down. But you also remove the coagulant, a lot of the coagulation factors, and that's why in outpatient world, that's non-life-threatening situations, I kind of like waiting, at least 2 days and sometimes 3 days, just to be on the safe side.
No, no,
Because
it's a
that
good point. It's because with fibrinogen at least, that is the thing that's going to come out all the time. And so I think that even measuring fibrinogen after the each session is probably a good idea, because if it gets below like 100 milligrams per deciliter, sometimes it means you got to stop using albumin and move on to FFP in those situations. So yeah, I think that extra time can be really useful.
and what we're going to say is that, well, we get closer to the end, the indications that we tend to use them for are not life-threatening, and so we're not going to use FFP. We're just going to go slower uh, with the issues. And as far as the hypocalcemia, it's the ADC, the deck the of the citrate, that binds the calcium, and that's what we use. So we just go slow. I think that's the other big issue for our patients. And why one of the reasons that I bothered to, I said the reason I found a plasmapheresis machine was for two reasons. One, for me, because I actually think it's a very powerful anti-aging device. But two is because we have some really, I mean, amazingly qualified people in the Bay Area doing, at least I shouldn't say, I don't know how that many, but we have one, Dr. Kiproff, who is, like, I consider the dean of plasmapheresis. He's an immunologist who's been doing this since, I think, 1979. So, but they tend to go quickly, okay, because the machines can run at 140 cc's a minute. In order to do that, you need a very large catheter, and he usually uses, and with our patients, that is a big issue. But the other issue is just when you start having the fluid balance at that level, when you're moving that fast, when you're filtering that quickly, there is a lot of some hypoglycemia, which isn't that big of a deal, but just the change in the blood, in the blood volume in the body is enough to trigger, especially our mast cell patients, or a lot, I mean, we have to remember that in our population of our chronic, we call them the chronic complex illnesses and whatever is going on in them, they are fairly fragile. And things you can have, severe disease and be very strong and resilient. And some of our patients are, but most of them aren't. And so the flow rate can really set them off. So, and then many times, we used to send people for plasmapheresis and they'd go once and they would feel so bad. we couldn't get them to go back again. And so I think flow rate is really important to assess for what the patient can tolerate. And one of the indications, actually most of the indications that we use it for are not in the list from the American Society of Apheresis, because except for the PANS and PANDAS, and we have riffed on that, figuring that most of our patients with long COVID and with chronic Lyme and Bartonella are in that category that may benefit from apheresis. Again, not first line therapy. I consider it the end of the line therapy. Okay, because it's just costs too much money. Also, the issue of vein access, as Steve alluded to, is really important. We can get away with our machine running it at 80 cc's a minute, even a little lower, but if it's a little lower, it keeps making the nurse work really hard, having to reset it. But so we can get away with sometimes with a 20 gauge needle, which again they wouldn't tolerate in most institutions because it takes too long. Okay, the slower you go, the longer it takes. But that's often what's necessary. Now, people, if you have access to an anesthesiologist or a very adventuresome doctor, you can use radial artery access. But that's not something that I would do in the office. And also femoral vein is a possibility. And I know some of the places in Europe do that actually routinely to help access. But I'm sorry, I was looking for the Q&As. I was going to throw a few things there, but I've lost my cursor, so I can't find the Q&A. So let me just go a little bit more tell me a little bit about the machines that are available in America. Okay, because the reason it's a big deal is because these have to be FDA approved. I mean, obviously you can't just do what you want. And in America, the two main companies are Optiva, actually, it's Terumo, the same people who make the catheters. Optiva, they have a device, the Spectrum Optiva, and also the Fresenius Kabi people have a machine called the Amicus, and that's one we have. The nice part about the Amicus is that it is someday, if the FDA ever approved the filtration devices that they're using in Europe, we could be using them. Okay. And so as I see, one of the first questions is, what are the different types of filters? Can you target specific types of toxins, such as mycotoxins versus metals? And the answer is yes, you can, but we can't. Okay. In Europe, a lot of people are using what's called ionospheresis, which is a filtration method that uses filters. Our device uses centrifugal force and separating things by their molecular weights or their density, I guess, more. Unfortunately, we don't have availability of those filters in America. Now, there is a device that's licensed in America that is designed for one purpose only in America, and that's to remove lipoprotein A and other forms of hypercholesterolemia. And that is a filtering device, and that one looks like would probably work for microclots. Okay. Whether it can remove other toxins is a question. There are strong opinions on either side. But so anyway, so basically, so if you're trying to remove specific toxins in most of the available devices in America, you really can't. Now,
Eric, can I just interject for one second about that? Because you're right, there's a lot of debate about that, and there's some practitioners that are using it for more than just lipoprotein. Yes. Apheresis, yes, it takes out cholesterol. We know that. There has been, a fair amount of work, and this uses dextran sulfate, and that's the one that's approved here and the selective apheresis, lipoprotein apheresis. But there have been some studies. There was a list, the guy Moriarty, who's a big guy in this cardiology, MMP9, it takes out CRP, galectin-3 somewhat, not as well as we'd like it to. Does take out fibrinogen, oxidized LDL, VCAM, Pla2. So it does take out quite a few other things, but the important one, not antibodies, does take out some cytokines. It's but variable as well.
Yeah, and I said that this is an area that I think we could do a lot more if, but again, the issue we have in America is that the FDA, you have to have a company willing to spend the money to get these devices approved. And that's a very expensive proposition, and nobody seems to be willing to do it here. Now, the and comparing this, I mean, EBU, I was just throw that in there, I should mention, because everybody's talking about EBU these days. What EBU removes is really questionable, and in fact, there are different types of EBU. This is just a side note, and one of them uses the dialysis filter really just to deliver the ozone into the blood. It doesn't really filter the blood. There is an EBU device that does actually use the filtration on the blood, and that probably does remove a level of toxins. I'm not aware that it removes much in the way of what level of antibodies. I mean, that is something I think I need to look at more in more detail, but it's not going to remove a lot of the antibodies. And the antibodies for the right people are the big thing, because in Europe they use inapheresis is the kind of the rage in many of the clinics in Europe, and I've sent people for that because it is helpful for the toxin loads. It really works well. But if people are having problems because of persistent antibody levels, especially like to the muscarinic and adrenergic antibodies, it doesn't work for that. I've measured that. It's clear. The antibody levels do not go down, and they go down dramatically if you use the plasmapheresis. You know, so that was some of the questions. And and the thing with, since we're doing the plasmapheresis, again, there was a very good question here. I'm looking at my list of that. Yeah, the whole idea is as you remove stuff, you're going to get more stuff coming out of the tissues. I mean, that's why we get all the antibodies out, because most of them are in the tissues, or not most, but at least half. And that will the osmotic and diffusion gradients will allow those to get more and more into the blood. So that's why, somewhere between 5 and 7 sessions are the best. Let me see if there's other things that I wanted to cover that I thought were really important. Just a little bit about, for interest's sake, Steve mentioned how long this technology has been around. Well, the modern quote technology has been around since like I think the early 70s. They started really using it for separation, for getting donors, getting white blood cell donors for people who are undergoing chemotherapy back in the day. And unfortunately, the machines themselves haven't changed much. The software is new, but the basic mechanisms of the machines are like basically 40 and 60 years old, which is really another sad thing for the state of affairs in America. But they work, and they are safe. I just want to emphasize, I think most of the side effects that people report are because of flow rates, is that not realizing you're working with fairly sensitive patients who are really sick. And just because you can run a machine at 140 milliliters a minute doesn't mean you should. And I think that's a really important safety issue. Steve, did you have something you wanted to throw in
No, I
here?
was just looking at some of the details about just following up about 45% of IgG is extravascular, right? So to the point about that waiting to let some of this come back into into the blood, is important. That doing one session is definitely not the way to go because we are going to be getting big osmotic changes, especially when we're using yeah, when we're using high volumes and we're doing this a lot. And so there's going to be a big and slow, sometimes slow movement of many of these call them toxins, but in many situations, antibodies and other cell chemicals are going to be coming back into the bloodstream over time. And so what we haven't been able to really see with all of the things that we're looking for is what's the rate that these things come back in. So I mean, it is quite amazing how little research there has been done. Part of it is like just the way that this is described. It's a little bit of a fishing expedition, right? We're trying to get out toxic substances. And a lot of times we don't know what the toxic substances are that we're trying to get out. So of course it's going to be very hard to know how fast are they going back into the bloodstream from the tissues. Like in the sense of heavy metals, for example, like if we could use a chelating agent on one of these, cascade filtration systems, but how many times would we have to do that? How do we push that? So there's so many unknowns. We still, despite how much literature there is on this, it is still really the Wild West.
Yeah, well, because the literature is mostly from hospital-based units, which are focusing, and they're run by immunologists and nephrologists basically, and they're not thinking the way we think about medicine, unfortunately. But the idea, we are looking to send out some of the what we get out to the lab that I used to use in Germany has been closed for the last few months because of the I think the death of the founder. But hopefully we'll be able to get a better look at the biological toxins that may be coming out. Because remember, things that are bound to albumin will come out very, very well. We will get them out. The difference is that the filtration-based units, I mean, especially we're all talking about the encephalopathy, the double filtration unit that's used a lot in Europe. And that seems to work really well for the toxins. And I said it before, despite what they say, when my clinical outcome from my patients and I have measured, they have a poor removal of antibodies. And the antibodies, it seems, toxins, if you get out, let's say 20% of a toxic load in the body, that often can make a huge difference because it is very often a numbers game, a load game, and that maybe your body can then handle the rest. But with the antibodies, because there are some devices in Europe that they use that remove about 60 to 70%, and they use them in Europe and Japan. These are filtration units that are designed to also remove antibodies, and they get about 60 to 70% of antibody load out. And clinically, I can tell you it's nothing compared to what we can see with when we get 100%. Well, because after about 5 plasmapheresis, we've gotten about 100% of the circulating antibodies and even the ones in the tissue out. And because we're trying to get, I mean, this is my concept. I shouldn't say mine. I didn't make this up, but it's the concept that kind of sticks with me, is that we're trying to, as they say, reboot the immune system. We're trying to remove information that's not useful. And we don't really know for sure what we're removing, but when most of our patients who seem to have problems with immune dysregulation, where they have really high antibody levels to lots of bugs that they don't really have active, at least it doesn't appear that they have active infections with. In my mind, this is a T regulatory cell problem, but like in the frustration and beauty of the body is that it's not a linear thing. When your T cells aren't working well, it doesn't mean that you have to fix the T cells. If you remove some of the information that the T cells are working off of, that being the antibody levels, sometimes the T cells start changing their tune. And that's what we seem to find is that because the Tregs start to work appropriately and tell the B cells that are making all these antibodies and aren't necessary to go and die, to go away, because they shouldn't be there. We're so used to seeing, everybody's EBV, HH6, CMV, parvovirus, Coxsackie viral levels being really high. Now, sometimes that's true because many of these people may have tissue reservoirs that we can't find or haven't responded. But sometimes we can see that when we treat their Lyme, those viral titers go down because the immune system is now working. When it doesn't have Lyme giving it misinformation for Lyme's benefit, the T cells and B cells start working, and then the T cells tell the B cells to stop making all that garbage, and all those antibodies are also activating the innate immune system, and you wind up with all our sickness behavior that our patients have. So it's a circle, and this is one way of changing that pattern. Now, many people are working with a lot of the new MABs and all that to try to change this equation by blocking specific cytokines or knocking out specific T cell or B cell lines. We've tried this with Rituxan. So these are all ways of interfering with the system. The nice part about plasmapheresis is that if done, and I'm going to let Steve talk to this because this is where I think Steve's work has been so important, is if we remember that we have to be controlling these infections while we're removing the antibodies, I think people do really well. So Steve, can you talk a little bit about how your approach and our approach
Yeah,
to...
so I started using this and sending people to Germany, sending people to Lyme, Mexico, and for PANS, especially Lyme-induced and Lyme-active PANS patients, and I found that plasmapheresis alone could be a bit perilous, finding that if we don't replete them with some of those antibodies that we've taken out, if we don't replete them with IG fairly quickly, then sometimes bad things can happen when there's an active infection. And so even more to the point, and I learned this initially from Dr. Zubčević, and then saw it quite a bit, have seen it quite a bit for the past few years, is that those folks particularly who have Bartonella infections, if you don't chase plasma exchange with antibiotics, then there's a really can be a very extreme Bartonella flare. We've seen this numerous times of patients who have had Bartonella and sometimes even occult Bartonella, where that we found later, and who actually did quite poorly with plasmapheresis. And so my strong inclination when I'm working with my patients who often are infected with the tick-borne infections and especially Bartonella, is that I want to do certain patterns. I want to do 3 treatments. Typically, I'm doing about 3 treatments a month, sometimes 6, but 3 treatments a month, whether I'm waiting 48 hours or what have you, and I'm doing 3 in fairly proximal succession. Each one, optimally, I'd like to use about 5 grams of IG, just a small amount. And then after that 3rd session for the month, then I like to use real doses of IG. 1.5.
IVIG for those.
Yeah, sorry. IVIG typically. You can use sub-Q. It doesn't have to be IV, but whatever. IVIG, and so using that because you've taken it out. And so if you're just adding albumin, if people have Lyme, not so much because so much of Borrelia is extravascular. So many Borrelia is so much more in the tissues, right? So you're still going to have some antibody there in the tissues, but some of these other organisms, I mean to Lyme some degree too, but I do think that repleting them with IVIG even a little bit after each session is important. And then after my session for the month, my 3 sessions, for example, for the month, doing a more substantial dose, like what I would use for autoimmune encephalitis, 1.5 to 2 grams per kilogram, doing that. And then a couple days after that, then using antibiotics. Now I can pulse those antibiotics, but if like for 3 or 4 days, just as a wallop, or I could continue them on for a few weeks, and that really depends on the patient. But I do find that if I can add antibiotics after IVIG, after the plasmapheresis session per month, that those flare-ups that these really heavily infected patients are getting they're really minimal problems, and they do get better.
Yeah. And it's using, I mean, and for people, I mean, there are some people who are very concerned about the IVIG. They're worried because, albumin is, I say nothing is absolutely benign, but again, albumin is very clean. There hasn't been any, I mean, so actually, to be fair, IVIG in the last 15 years is also very clean. There's no infections. Um, but and allergic reaction to albumin is very, very, very rare. It's not something that is people, yeah, people have, I can say, yeah, almost no reactions to albumin, while IVIG, we have lots of people who have difficulties with albumin, I mean, with IVIG. So, and you sometimes, for those people, you'll use the antibiotics right after. So can you talk a little bit about that?
Right. So the if I'm gonna use minimal or no IVIG, then I'm gonna probably use something. I'm still gonna use something like even transfer factors, something of that nature. I do like to have a little bit of you can even use a little bit of just um, intramuscular, IMIG. But if I want to skip, if I need to, for some reason, skip the gamma globulin repletion after albumin, obviously it depends on the infection. But if I'm working on someone who has, let's say, Bartonella and Lyme, I'm probably going to use, agents like, ertapenem or meropenem, IV. You can use ertapenem IM, of course, but use that with an intracellular like azithromycin, uh, typically IV, but I'll use it orally as well. But I'll use the carbapenem and something that has some Bartonella coverage and has very good or very decent Lyme coverage when it's used with something else. So the cell wall drug I'll use and the intracellular, sometimes a double intracellular, and sometimes I'll even do the Zhang protocol right after a session where I'll do the daptomycin and then the ceftaroline or whatever cephalosporin I want to use with an intracellular and do like a 5-day IV therapy, triple IV therapy, and then give them a rest time or chase it with herbs or something oral until we're ready for the next session a month later. And I'm finding that 3 to 6 months of sessions, often 3 is enough to make quite an impact. I'd like more data to really answer that cleanly. There's a lot of reasons why I can't get that data, but mostly because we don't have enough people who are doing this in the office. So, what I am finding though, working with you and working with Kiprop and working with Omar in Lyme, Mexico, Omar Morales, is that this is a safe and fairly easy to do procedure. Once you get the right people up and running with this thing, it's not that hard to do.
Yeah, I mean, well, I have to just remind people, I mean, one of the big drawbacks for this is the expense. It's unfortunately a very expensive procedure. Um, and yeah, that's why it would be nice. This is when it would be lovely to get insurance to cover. Um, uh, and we try to do that when we can. I mean, when we can get insurance covered, we send it to it's usually uh you know like UCSF or somewhere to get it covered.
Right.
Uh,
I mean, that's the thing, right? Like we haven't been able to find that model where, because we do have a lot of patients where we get neurologists who diagnose CIDP in these folks, or we have a covered diagnosis like a 1 or a 2, category 1 or category 2, that's going to overlap and that they will qualify. And then it's like, but are they going to qualify as an outpatient process? And so that's been really hard. Like it's right now, it's still cash pay for almost everybody, unless we do it at a tertiary care place.
yeah, and that's difficult because then it's difficult to do. They kind of control the protocol, and that makes it difficult to follow with IV antibiotics when necessary.
And the IVIG for that matter. That's even hard. A lot of people really push back on using that gamma globulin repletion.
Yeah. Well, again, because they're coming from a different model of the patient. I mean, just getting people to, I mean, it's really been an amazing tour de force, I think, of I think interested parents and a few special doctors who've gotten pan this covered. I mean that's pretty amazing. It wasn't too long ago that the medical establishment considered that we were enabling poor psychiatrically damaged people, trying to give them a disease to cover the fact that they suddenly are incredibly obsessive or have other significant problems. So the the interest, I just want to talk a little bit about a sidelight of plasmapheresis. Is its application in the well, maybe call it anti-aging, but life preservation for old people who aren't willing to shuffle off so quickly, or maybe not so old people, uh, is that there was the original experiments, where they the young, what people now call young blood, where they were paired animals, old animal paired, with vasculature hooked up to young animals, and well, lo and behold, the young animals started like looking older, and the old animals, started looking younger. And that in fact, there is a group right now who's doing a study on on giving people young blood. Um, but there's been further research that strongly suggests that that's not necessary, that it really isn't the blood. It isn't some magic properties in the young blood. What it is removing the garbage from the old blood, and just dilution. As they always say, the if you have an infinite world, the answer to dilution is, I mean, the answer to pollution is dilution. And fortunately, in a finite space, that doesn't work. But with the human body, it looks like it might. And in fact, Dr. Kiprov, who we speak of, has an ongoing study right now, along with the Buck Institute, where they're looking at 40 controls and 40 patients, where they're doing I believe it's 5 or 7, I forget, plasmaphereses. And they are following, as you can imagine, it's with the buck, an amazing number of markers of aging, both biochemically and a bunch of other, questionnaires, of course. And this is a double-blind but study. But what they're doing is that, of course, everybody's going to get the plasmapheresis, but you might be part of the first 40 that have to go through the sham process, which doesn't sound like fun. But anyway, this should really maybe give us some real data, because there was a Fresenius Kabi did help fund a study for Alzheimer's about 8 years ago that came back with kind of like mixed results. And like many studies, it really depended on patient selection and just how many apheresis were done. But it really looks like, since it is there's so much, there's a lot of talk now about senescent cells, and senescent cells are cells that have kind of like left the reproductive, they're not reproducing. And this is a good plug for my good friend, Dr. Navio's concept of the cell danger response. These cells are stuck in various steps of the CDR. Basically, they're either making a lot of inflammatory chemicals, or they're just kind of quietly growing and making lots of chemicals but again, they're still letting the body know that there's that tissue isn't healed in tissues, or you have the cells that are just not communicating well with the ones next to them. Anyway you cut it, these cells are producing exosomes, because remember, that's how our cells communicate. Exosomes aren't just things to wrap messenger RNA in and make vaccines. Exosomes are one of the ways the body communicates with itself. And anytime you have an unhealthy cell, it's producing signals through exosomes and all the other cell signaling molecules that it produces that are not telling you that you should be vital. Okay, they're telling you you're sick and you should have less energy, and tissues fail over time. And plasmapheresis, by removing a lot of this stuff, and that's the thing, we say stuff because everybody keeps asking, well, what's in this stuff? What you're removing? We know a lot of antibodies are, but to be honest, I'm not aware of how many people have been measuring this. And I said, we are going to start sending ours out for study. I'm finding it's just that it's hard to find labs in America that will give us the complete look at what we want to see. And I said, we're working with 2 German labs, and hopefully we'll have that going soon, where we'll be able to tell you what's coming out and maybe compare it to what people are getting with EBU, because these are questions that we should know the answers to. And how does it go? Who wants to pay for all the work? And we're going to pay for a bunch of it, because we really got to know. We really want to know better what we're doing and who we're helping. We have our clinical experience, but that's still such a small sample of what's out there and what's possible. So, Steve, any comments, thoughts?
No, I mean, I think that it is still, there's so many opportunities here to help people. I think one of the frustrations I do think is with different adsorbents that we can use and different kinds of filters. It becomes a real question, especially in the ME/CFS world, that that we don't want to necessarily get rid of all the antibodies. But what are the filters that we're after? What are some of the adsorbent substances that we want, so we can keep people's plasma? We can replace, give them back their own plasma, and then that just minus a few things. So I really think that that's where I'm interested in going with this, is trying to find the right filters, like I know Isaac Elias has been trying to get, he's developed a filter that very selectively binds galectin-3, much better than the lipo protein apheresis, but he can't get it approved very easily in this country. And so for him, with that molecule, I think it would be all important for some of his results. And I think there's a lot of other researchers out there who have that chemical that they just want out of the body, and this would be an amazing, branch of work for us to help people engage in.
Yeah, all we got to do is figure out how it doesn't cost $100 billion to. I mean, it's the testing that's the problem. I mean, to be fair, the FDA, his job is to protect people, but sometimes the level of the level of evidence gets a little carried away. And again, and as people have asked, how expensive is per person? Generally, the price range is usually in the Bay Area between $500 and $6,500 a treatment. So if you're going to do 5 of them, somewhere between 35 and what does that be? 6,
25 and 35,
yeah, 40 something $1,000. So it is not cheap, unfortunately. That's why I say this is should never, this isn't a first line therapy, but this is a therapy that in the right person can really make a big difference. I think in someone with I think for long COVID, I think I have a cleaner. For people with PANS and PANDAS, it's really clear. If you have anybody with high autoantibodies to some of the the central nervous system antibody markers, and their symptoms are consistent, the results can be really dramatic. Long COVID, again, because if those antibodies stay high over time and you've done all your tricks to remove residual spike protein and do whatever else you can do to change the milieu, and they're still high, it's worth doing. And remember, I just one last little note about antibodies. Um, well, I'm saying somebody keeps asking. Yeah. So the machines do remove toxins and pathogens. They do. I mean, the center, because anything that's attached to albumin, and since many toxins are attached to albumin, um, that will go. As far as pathogens, um, I don't know if I mean, pathogens are usually in cells. I don't think that many of them are attached to albumin, so I don't think we get much in the way of pathogen removal. But you definitely will remove anything that's attached to an to protein. That definitely will go. Um, and I was in the middle of making a point when I saw that question, and I forgot the point. So I need more plasmapheresis. Um, no, I think that's what I was going to say is the long COVID people is a clear, I think is a clear one for the persistent um, proteins. But I just want to add something. There's interesting research now, and it's um, because autoantibodies turn out that they may not be bad things. Okay. The problem, like everything, might just be the amount. Okay. It looks like that a lot of the autoantibodies that we see, for instance, in long COVID, are directed at receptors, anti-adrenergic receptors, anti-muscarinic receptors, and that low levels of those antibodies actually might be part of our of communicating, of actually getting those receptors to work better. And it's when the receptors have failed that the high levels of the antibodies that the levels start going up. And then the problem is when the antibodies get too high, the body starts to then probably attack uh, the cells with the receptors on them, because there's crosstalk in the immune system. I mean, if the antibodies are high, your T cells and your innate immune system is going to start to target those tissues. But really, the antibodies might not have been the problem to start with. And this is why, again, this plasmapheresis is a very expensive Band-Aid. We still have to get to the underlying problem. I think that's one of the things I think that's really important for people to understand, and why it shouldn't be ever a first-line therapy. Again, unless it's a toxin that's going to kill you.
Right. I mean, I think that I look at it as a tool to help us get to the other side, but using the other things that we know what to do. And I think using it strategically and setting the right timing for it, I think it has amazing potential and great use already that we've seen. But I think that if we could use it as a piece of everything that we're doing, but not the end all and be all, that's how it's going to get these patients better.
Yeah. So so I think to sum up, Steve did a good job. This is an amazing tool, but it's just part of a process, and we're hoping that we can someday get the rest of the medical community to engage more in the discovery process, and get this out there so it is not such an expensive end stage treatment. But I think we could probably make use of it to allow treatment to be tolerated earlier in people who are super reactive. I mean, what would be interesting is to see how this affects mast cell activation in the future. And that's something hopefully we'll be able to come back with and get to have some data on moving forward. So thank you, Dr. Harris. As always, it's fun to have a time to chat with you. And I hope we've given people some ideas, some things to think about in a tool that not many of us use, but one in the right patient at the right time can really be life-changing. So thank you all.